Absolutely. Well, good morning, everybody. I see that people are continuously joining in, so I'll make an introduction, and I guess we will go straight to a very fascinating talk on myopia. And so, first of all, I'd like to introduce Dr. Dorchin from University of Alberta. So she has a very impressive CV, and basically she's the clinical associate professor at the University of Calgary. And she finished her medical training in Saskatchewan, and she did her residency in Dalhousie. And she's one of those special pediatric ophthalmologists who also did 2 fellowships, one at Moorfields Eye Hospital in London, my hometown, which is great. And then she also did one in Philadelphia. So she's extremely experienced and well-trained in pediatric ophthalmology and strabismus. And to top that up, she's the coordinator for the RFP program in Alberta. And she sits on quite a lot of boards and committees. Most importantly, she was the past president of the Canadian Association of Pediatric Ophthalmology and Strabismus. And she is the current president of the EPSA, which is the Alberta equivalent, or EPSO, which we all know is vitally important in making sure that ophthalmology is heard and all the good things are done in terms of our specialty. And she also sits on many other national and international committees. She's very heavily involved in teaching and medical students and residents in particular, and is on several editorial boards. So she has extremely sort of a highly regarded reputation, and is regarded as a very good academic clinician. I have heard her talk about myopia before, and she has a very comprehensive and deep understanding of the topic. And I'm sure all ophthalmologists get asked at parties, if you have any parties these days, about various things like, my doctor said this lens implant is better than that implant. Should I have it? The other one is, should I have laser surgery? Why are you wearing glasses? And the other one is, my kid's got myopia, and what should I do about it? So I think if you want to be fascinating people at your next party, then we definitely should listen to Stephanie's talk on this. Over to you, Dr. Dorchin.
Thank you, Camille. Thank you, and thank you for having me. I'm sad that I can't be there in person, but someday we will have travel. We keep saying someday. So my talk is about myopia. I've called it, I do like bad play on words, probably not as much as Dr. Kraft and his puns, but the long view myopia and its treatment. So these are my financial disclosures. It's funny that Camille should open with the statement about a party, because that's exactly what I was going to do. So I said, just suspend disbelief, and you're not in COVID right now, and you're actually at a dinner party, you strike up a conversation with an acquaintance, and what happens? They find out you're an ophthalmologist, and exactly as Camille suggested, oh, my child's myopic. Do you mind if I ask you a question? That's usually how it goes, right? Someone who's non-medical, do you mind if I ask you a question? And of course, most being polite will say, sure, of course, those polite Canadians. And then they'll go on to ask you about their child being nearsighted, and should they have special glasses, or should they be treated, and what was the cause? The fact that Camille is commenting and I'm saying the exact same thing just shows you how often people are being asked about myopia. So the objectives of today include to understand the burden of disease of myopia. If we don't understand the problem, how can we understand potential solutions? To outline the pathophysiology of myopia, and to actually discuss different treatment options. Now, this is a very, I would call a hot topic in ophthalmology and in optometry in general public right now. That to cover all aspects of myopia is just in 45 minutes is actually just not possible. So if we look at publications over the last 70 years, you see from this graph, this is Pubmed, that the number of peer-reviewed articles available in the last 70 years has really taken off. And it was really kind of in 2000, you almost see this kind of exponential growth in myopia publications. Myopia is now being coined by medical and lay people alike as reaching actual epidemic levels. And because of that, that's what spurred on this dramatic interest. So if we look more at the increased interest in the public domain, if you look at the number of Google searches related to myopia and nearsightedness, you can actually see a significant increase in the actual search term. So here on the x-axis, again, we have time, and on y is Google's what they call their popularity index. So it's a score that reflects how often their term is liable to be searched compared to other general search terms. But so what does that actually mean? So to give some context of the y-axis, I've compared it to everyone's favorite child phenomenon and an earworm at 7:30 in the morning, and that's Baby Shark. I kind of beat myself to the punch. I can see some people bobbing their heads, and some of you might be doing it in the background. So you've got your earworm for the morning. So if you find yourself singing Baby Shark for the rest of the day, it's my fault. So if you look at Baby Shark, you can see that, you know, there's generally not a lot of interest, and then that phenomenon just becomes really, really popular, and it's starting to die down, and hopefully it will die even further. I find singing Baby Shark in the office to some of my patients really trying. So it's important before we continue this discussion to actually define our terms so that everybody's on the same page as exactly what myopia means and high myopia and pathologic myopia. So as we all know, when the actual definition of myopia is when the eye is at rest, the light rays are brought into focus in front of the retina, as you can see in this diagram here. Versus normal, as we all know, it focuses directly on the retina. Now, the WHO actually defines myopia as a spherical equivalent of less than 0.5 diopters, or equal to or less than 0.5 diopters. High myopia is less than or equal to 5 diopters. But the reality is that you'll see in research, sometimes they'll define it as -6 diopters. So there is some discrepancy there and some play. Pathologic myopia as a general rule is considered to be about -8. And the other way that people define it, and you'll see in a lot of the studies, is axial length, measuring axial length. So high myopia is 26.5 millimeters or more, and pathologic myopia is 32.5 millimeters or more. So what is the cost of the disease? So myopia has emerged as one of the 5 ocular conditions that the World Health Organization has actually identified as an immediate priority for the elimination of blindness. In Asia, 90% of teenagers are myopic. In Singapore, 96.5% of men are adult men are myopic, with 20% of the population being highly myopic. So, and their classification was -6 diopters or more. So there you can see some discrepancy. So this is in contrast to 60 years ago, when only 10 to 20% of the Chinese population was nearsighted. In 2020, it was actually estimated that 2.5 billion people were affected with myopia, which is actually 1/3 of the population. And the economic burden is estimated to be anywhere between 2.2 billion and 202 to $268 billion US annually. The annual expenses of myopia treatment are estimated to be greater than other ocular diseases, including macular degeneration and primary open-angle glaucoma. Also non-ocular conditions such as Parkinson's disease and COPD. So the burden is significant. And the burden isn't just happening in Asia, it's actually happening all throughout the world. So if you look at this little diagram, I'll just draw your attention specifically to the US. And in the United States alone, they've had an increase over 30 years of myopia prevalence going from 25% to 42%. But we're seeing this increase throughout the world. More of the developed countries are going at a much faster rate. The UK is also increasing. You can see here, Australia is even increasing, and a lot of the studies are based, some of the light studies that we're going to talk about are based in Australia. And many of you have probably read this article or seen this article, or it's been referenced to obliquely. It's a very, very common article related to the global prevalence of myopia. And I actually want to draw you to attention to this graph, because this is where the money is, I think. So if we take me, and I'm going to date myself now, I keep thinking of myself as young, but I'm slowly creeping up that age group. So if you look here, what you have is you have the number of myopes. And so the number of myopes is left here, okay, on the left column. And you can see that in 2000, I was in this cohort here, the 20 to 24 range. And the largest number of people with myopia were within this cohort. So they are the dark bars, okay? So you can see that this here, these dark bars, is actually the largest cohort. And then in 2050, I'll hopefully have, oh, hold on, there we go. I'll have hopefully been able to age gracefully. And I hope I look a little better than this, but they suggest that you're going to actually see a spread of the distribution. So these light bars are 2050, and you can see that you're going to have high rates of myopia starting in the, starting to increase from the 10 to 14 group all the way up to the age bracket that I'll be in 2050. And if you take a look at my daughter here, my daughter, by the time in 2050, she'll be in her 30s, 400 million people will be estimated to be myopic. And if we look at the prevalence here, these are the lines. In 2050, she has a 65% chance that she will be myopic. So if we look at this another way, so what Holden did is, from that article, is he's also produced these, which are a little more kind of user-friendly in some ways, and I think really gets the point across very, very nicely. So here we are, 2020, you see the estimate of number of people, number of myopes, with our prevalence being at 33%. And by 2050, you see that increase of almost 5 billion people, with 52% of that population being myopic. If we now look at high myopia, again, so those are people, -5 or more, we can actually see that by 2050, 10% of that population, almost 1 billion people, will be highly myopic. So what does this mean for ophthalmology? Well, likely we'll be busier than ever, more cataracts, more glaucoma, retinal detachments, myopic macular degeneration, low vision because of irreversible vision loss. Already in some regions, myopic macular degeneration has been found to be the most frequent cause of irreversible blindness. And it's actually myopia is actually expected to become the leading cause of irreversible blindness. So I hope I've convinced you that the burden is significant. But why does this happen? What is the pathophysiology? To date, the prevailing theory regarding causes of myopia is related to dopamine and light. The theory was first developed using a chick model, and the chicks were fit with these goggles, and you can see an example here, that alter the resolution and contrast of incoming images, which, resulted in the chick developing myopia. They then went on to inject these chicks with dopamine into their eyes that were deprived of light, and found that this actually had a protective effect. Subsequently, they went on to actually inject a dopamine inhibitor, and it was found to abolish the protective effect of light. The leading hypothesis is that light stimulated, oh, sorry, there's somebody in the chat. Are we okay? Okay. The leading hypothesis is that light stimulated the release of dopamine in the retina, And this neurotransmitter in turn blocks the elongation of light development, elongation of the eye during development. So retinal dopamine is produced in a diurnal cycle, with it ramping up during the day. This tells the eye to switch from a rod-based nighttime vision to cone-based daytime vision. And they suspect that under dim light, the cycle is actually disrupted, and consequently you get eye growth. So probably the most interesting part of the talk and where everything is growing is in myopia control. And I try and simplify things because I find that's easiest for me. And the way I think of myopia control is two current ways. These are the ways that we have. We have one is to slow the onset, and the second is to reduce or slow progression. So once we're myopic, how do we slow the progression? We know that children who have early onset of myopia are most likely to actually develop high myopia, right? Makes sense. The younger the child is that they become myopic, they've got lots of growing to do. Those are our kids that are going to be highly myopic. And, this may be recall bias on my part, or it may actually be true. And I'd be curious to hear what other people's experiences are. But I'm not just seeing young children getting myopic early. I'm seeing young children who are highly, highly myopic also more frequently. So I think the record for me is I have a 2-year-old who came in with we're talking no other ocular pathology and fully investigated, and he was -17. So let's look at our treatment options. So let's look at slowing the onset. So one of the very important papers to look at myopia actually came from Australia. And this is what kind of really sparked the interest about sunshine and is a common known method of kind of slowing onset. So this study actually compared children of Chinese ethnicity that lived in Sydney and those compared to those that lived in Singapore. What you can appreciate is the prevalence of myopia is actually much higher in our children in Singapore than Sydney. Axial lengths and anterior chamber depths were also significantly greater in these Singapore children. There are many factors that they actually looked at to see. One was parental myopia, which, as we all know, is associated with a greater likelihood of myopia. And there was actually no significant difference between the parents here. So you can see the myopia rates of the parents right here. The children, they also looked at near work factors. So reading books, near work activities. And actually, if you notice, the children in Sydney actually did slightly more, were reading books slightly more and had actually more near work activity than the Singaporean group. But the largest difference that they found was the number of hours spent outside, and it was actually significantly different. And it was this study and others around that time that felt that they proved that the number of hours outside is a really important factor in helping to prevent progression or prevent myopia. So, we all live in, we don't all live in beautiful climates. I've heard you guys have had a lot of snow recently. So it's easy to say to go outside, but it can be harder than it looks. So sometimes all the kids get is actually in Canada is recess, but even that can make a big difference. So on the graph on the right, this is a Taiwanese study. And what they did is they divided kids as either having recess outside or recess in the classroom. And the recess amounted to 80 minutes per day. And they found that the actual simple intervention of recess outside or not, myopia rates were significantly less. So I'll kind of walk you through this so that you can see it. So this is our recess outside group. And these children, 47% of these kids were already myopic at the time of the study versus 49%. And then the dark gray is the the children that had no myopia by the end of the study. And then this bar is the one that you really want to pay attention to, and that's that middle bar. And what you see is that the rates of myopia developing new myopia is significantly different, with the control group about 17.5%, and with the recess outside group only 8%. So the question becomes, okay, so that's great. How many hours? Like what's the money? What was the difference? So the number of hours outside between the two groups was 11.6 in the 11.6 hours per week in the recess outside group versus 7.6 hours outside. So I think we can all agree that outside time is a key environmental determinant for myopia. And it's estimated that if you spend 14 hours outside, for every hour, you have a 2% reduction in the odds of myopia, okay? So maybe we should just leave our kids outside all day. They could do research outside. They could do school outside. But the reality is that it does seem to top out 2 to 3 hours per week. So a maximum risk reduction of about 28%. So the recommendation, as you may have heard and already know, is 2 to 3 hours of outdoor time per day. So just to give an idea and underline or emphasize how problematic myopia is, Singapore has actually developed a public health, deemed this a significant public health issue, and have put a lot of dollars towards this. And they've actually done a public health campaign to encourage children to get outside. But although sunlight may slow the onset of myopia, it does not seem to affect the progression of myopia. So what that means is that once you're myopic, it doesn't seem to stop or slow the progression of myopia. And there are currently some studies that are looking into this a little bit more. The COS had the gentleman from Singapore a couple years ago, and he was saying that the ATOM group is actually trying to look into to sunlight. So Amandeep, before we started chatting, actually was very astute and brought up a question about how is COVID-19 going to actually affect our myopia rates? Are we going to see a spike? And you know, there's actually quite a bit of research, and I just picked one article for everyone as a starting point that you could read. And this looked at what happened to the rates of myopia during COVID-19 lockdown. And what you can actually see in the article is that the incidence of myopia in these children actually doubled between November from 1 year before. So the incidence from November to December 2019 to the November, December 2020 actually doubled compared to the previous years. So that is quite concerning. I'll be very interested to see the actual rates of myopia and see if we can actually see an increase in the spike when those numbers come out. So while most of the popular media focus on the role of light exposure, many would argue that this is perhaps an oversimplification of a very complex problem. And I would agree with that. So case in point is this study coming out of the Netherlands. And those of you who are unfamiliar with this Generation R study, I would strongly encourage you to look this up. So this is a massive initiative put together in order to examine the environmental and genetic factors that are associated with both healthy development and aging, as well as disease risk factors, disease onset, and disease progression. So with respect to myopia, what they had is 5,800 children were enrolled between the ages of 2002 and 2006. And these children have actually been enrolled since birth. And myopia is not the only thing that they're following. There's a whole bunch of things. So specifically related to the myopia, in this study, 3,422 patients received eye measurements. and were actually assessed for myopia. Parents actually filled in questionnaires and provided information regarding time spent outside, reading habits, screen time. Children also had a full genotype analysis, and parental myopia was recorded as well. The results of the study are actually worth noting, that while outdoor exposure was a significant predictor of myopia, or lack of outdoor exposure, I should say, the relative effect of reading distance, and by reading distance, we're talking about less than 30 centimeters, and number of books read per week were a better predictor of myopia. They also found that computer use was only weakly associated with predicting myopia, and TV was not found to be associated. So the authors noted that children who had a high environmental risk factor and high genetic risk factors combined showed a significantly greater chance of developing myopia. So what they did is to clarify, is that they looked at these different things and developed a score for each. And so if you look at this graph here, I think it's very telling. So this argument, is it nature, is it nurture? Well, I actually think it's both nature and nurture. So if you have what they consider a high environmental risk factor and high genetic risk factor, your odds ratio is quite high, at over 1.2 for developing myopia. And if your environmental risk factors are low, you can see that that drops quite significantly. So environment is very important. And again, if your genetic risk factor is low, it's also, but your environmental risk factor is high, the odds decrease significantly. But based on this, one could argue that maybe genetics is more important than environment, because the odds ratio in the low group is slightly less. So interestingly, though, I will note this, and they noticed this, that parental myopia contributes to both the environmental and genetic risk scores independently. And what they found is that the prevalence of myopia depended, as we all know, on the number of parents that have myopia. So if no parents were myopic, 8.3% of these kids went on to develop myopia. If one parent was myopic, 13.7%. And if both parents were myopic, that jumped to 18%. So I know they argued that screen time was not of significance in contributing to the prevalence or causing myopia. But I would actually argue that at least once a day in my office, maybe or more, I'm asked about screen time and how much time their children should have. I'm asked if it will make their children's eyesight worse. They also will ask me to tell Johnny that he actually shouldn't watch screens. I'm sure many of you have actually experienced that. So to date, there's still limited evidence of whether computer use is a risk factor for myopia. And cross-sectional studies have conflicting results, and there isn't much longitudinal data. That being said, there's still a lot of recommendations about how much screen time our children should have. And it's not just for myopia, obviously, but for other health factors as well. So the American Academy of Pediatrics have developed guidelines, and you can see lots of different guidelines all throughout the internet. So if you look here, children less than 18 months, no screens are best, and that's any screens, exception being video chat with family and friends, okay? 18 months to 2 years, it says limit screen time and avoid solo use. 2 to 5, maybe an hour a day. And at 6 years and more, they say, well, just be consistent and set limits. It is estimated that the average American child, school-aged child, has about 6 to 8 hours of screen time a day, and toddlers are as much as 3 hours a day, which is a lot of screen time. I think we would all agree. So still looking at the Generation R group, although they found that screen time, wasn't significant in their first study because of the paucity of data, and especially longitudinal data for the Generation R group. They looked at computer use on myopia development. And I think they had 3 really good aims from this study. One was to determine the association between computer use and myopia. The second was to relate computer use to other near work activities associated with myopia, which again are the amount of time reading, so the amount of time up close, and then the intensity of that near work. So is it more than 30 centimeters, less than 30 centimeters? And lastly, can near work be modified by outdoor exposure? Meaning, does outdoor exposure kind of temper that effect of near work? And so the design, they actually used a desktop computer, and outdoor exposure were measured at 3, 6, and 9. And I know everybody's thinking, yes, but what about iPhones and tablets and iPads? I haven't seen any good literature related specifically to that yet. So they used a questionnaire just like before, and outside time was determined to be low, medium, or high. Low was 7 hours or less, medium 7 to 14, and high was greater than 14. They looked at hours of computer use per week with a maximum effect of 40 hours. Anything above 40 was labeled at 40. Time spent reading per week and reading distance. And then the children had a cycloplegic autorefraction. So it's really important to remember, why is that important to be stressed? It's because some of these studies actually don't cycloplege the children. And so the actual incidence of myopia is likely overestimated, as we know, because of their accommodation. So computer use was actually found to be moderately associated with myopia. And the biggest predictor was the age at which you start to use the computer use. So use of age 3 years is associated with myopia occurring at school age. So there's something to be said for that no screen time before 2 years of age. One may argue even 3 years of age. Total near work, again, was found to be a risk factor for myopia, reading time and reading distance, and they were more strongly associated than actual computer use. And hours of outdoor exposure needed to prevent myopia depends on the intensity of the near work, okay? So if you have 7 hours or more, it can compensate for low intensity near work. If you have 14 hours per week or more, is needed to compensate for high intensity near work. So they're consistent in the style of graphs that they like. So here we go. You have mean outdoor exposure here, and you have near work risk score. So if you have a high risk score and very little time outside, your odds ratio is quite high at 1.16. But just from outdoor exposure alone, it seems to negate the effect of that intense near work. So you can see this nice drop off here. And you can see it not so much in the medium group, right? But more so in the low risk group. And if you're outside a lot, you can see that risk also, drops across your risk score. Again, proving the importance of outside exposure, and that it may actually kind of negate the effect of near work intensity. So, I know, the 20-20-20 rules as touted for dry eyes. Maybe we should also be using a little bit of that 20-20-20 rule to kind of break that continual near work and allow those eyes to relax their accommodation. So going back to this diagram, I think we've discussed outdoor time and tacked on some genetic factors, environmental factors there. But what about kind of reducing or slowing the progression of myopia? Most common and that everybody knows about is atropine. Atropine is a non-specific muscarinic acetylcholine receptor antagonist, and it's been used off-label treatment for myopia since as early as the 1960s. So the exact mechanism of action for myopia control is unclear, but it's thought to slow myopia progression via nicotinic receptor pathway. So it's thought that it there are two pathways that explain this. So atropine functions at a low dose via the neurochemical cascade. And also atropine has been shown to have direct effect on scleral fibroblasts by inhibiting glycosaminoglycan synthesis. Okay. So ATOM studies. These studies have generated the most discussion, I would argue, and I feel that it was the release of these studies that really kind of spurred on this wave of treating myopia and the real international interest in treating myopia. So ATOM studies are the atropine for the treatment of myopia studies. And they were randomized, double-masked, placebo-controlled trials involving 400 Singaporean children to start. These children had to have a spherical equivalent of between -1 to -6. So in ATOM study 1, children installed 1% atropine for 2 years. And there was a significant reduction of myopia progression by about actually 77%, and a reduction in the axial length elongation. There was significant rebound phenomenon for both axial elongation and myopic progression upon cessation of the 1% atropine. So as you can imagine, there was also side effects associated with it. So photophobia and decreased near vision being kind of the most common. So then they proved that the atropine helped, but the next generation came along, and that's the ATOM 2 studies. And they chose to do 3 different concentrations. And the 0.01% was actually supposed to be kind of a control in some ways. So they instilled the drops over 2 years and had a 1-year washout period. And in this study, the higher the dose, the greater the inhibition of myopia over the 2-year period. But when the treatment was stopped, there was an inverse dose-related increase in myopia, okay, during that washout period. So the higher the dose, the greater the regression. So the net effect was that 0.01% atropine was most effective in slowing down progression. So this is probably, of all the ATOM studies, this is the chart that you need to know. If you only have time to look at one thing, this is it. So if we look at the red line is actually our placebo group. And one can appreciate that the patients become more myopic. You can see this slow march, okay? This is your 2-year mark. This is your 3-year mark. And you can see that they've, by the end of 3 years, we've got them becoming more myopic by 1.4 diopters. So then we've got our intervention groups. So purple is our 1%, then we have our 0.5, our 0.1, and the green is actually our 0.01. So if you look at the purple, the 1% atropine, you can see that it slowed the progression the most, but as soon as it was stopped, there was a significant precipitous drop in that washout period, and their myopia progressed quite significantly. Again, these are our other concentrations, and once we start that washout period, one can appreciate that the 0.01% atropine regressed the least, had myopic regression the least. And actually at the 5-year mark, it regressed to about 1.38 diopters, which is similar to 1.4 diopters. So what the group indicated is that because of this, they concluded that 0.01% atropine will reduce the rate of progression of myopia by about 50%. So when I'm counseling my patients about atropine and low dose atropine, I express to them, and they say very specifically, nothing will stop the myopia, but this will slow progression of myopia. Interestingly, in this study, in the washout period, they did notice that if patients started to progress more than 0.5 diopters, they would actually consider retreatment. So also after the ATOM studies came the LAMP studies, And they, again, were looking at different concentrations. So here's your ATOM studies. Here are your LAMP studies. And LAMP, their concentrations were 0.05%, 0.025%, and 0.01%. And if you look at the results compared to the ATOM studies, they feel that 0.05% atropine is the best, with the proviso that that in this study to date, there has been no washout period. So they are currently in the process of doing a washout period studies. Interestingly, if you look at, here's where the money is. So after 2 years, ATOM suggested that the progression of myopia was 0.5 diopters. The LAMP study found that it was almost more than double that at -1 diopter. And similarly, you can see the axial length change was significantly more in there, 0.01%. And there was no one could really explain why such a significant difference. So that's the ATOM studies and low dose atropine. And when I actually treat my kids, I tell them that it will actually be for 2 years that we need to do the atropine. And I do worry, like everyone else does, about true compliance. And I personally still start at 0.01% and not 0.05%, because I have more children that are symptomatic with the 0.05%, and I also haven't seen the washout data yet. So moving on to orthokeratology, everybody talks about the pendulum swinging, one way to the other, and how things go out of popularity and then they come back into popularity. I would say that orthokeratology has certainly made a significant resurgence. And it's a significant area of interest for the treatment of myopia. So orthokeratology lens wear results in the lens being worn at night, as we all know. And during the lens wear, there's a flattening. So you can see that there's this flattening of the central cornea, which correct the central myopic refraction. And they also note that the aim is to also have this mid-peripheral epithelial or stromal thickening. I think I can see my cornea colleagues just cringing through the computer right now. The theory behind orthokeratology is that a regular lens would cause peripheral hyperopic defocus. So if you take a regular lens, it focuses on the retina, but in the mid-periphery, because of the way it's done, you actually get this peripheral retinal defocus. But orthokeratology, which causes that temporary flattening of the central cornea, will actually correct that central myopic refraction, but also change the peripheral refractive status from relatively hyperopic to a relatively hyperopic defocus to a myopic defocus. So you can see that it's bringing that image forward. Okay, so, hyperopic defocus and then bringing it forward. And this article is probably one of the most commonly quoted for the evidence for orthokeratology. And it's written by Sun et al. And it's in a meta-analysis. And they found that there was a 45% decrease in myopic progression with a mean axial length increase of 0.27 millimeters, less than the control group. But again, no washout period. And it did not evaluate the risk of myopic. So therefore, it didn't evaluate the risk of myopic rebound. Besides the cost, the biggest concern is infectious keratitis. 13.8 out of 10,000 wearers had an infection. And of all those, 10% had significant vision loss requiring corneal surgery. The American Academy of Ophthalmology actually has a paper looking at orthokeratology, and it's tepid. They don't take a stance one way or the other. They say that it's beneficial for myopia, but that we need to be cautious. I would argue just most ophthalmologists are not recommending orthokeratology, but I have seen that some of the ophthalmologists actually do. They'll send them to their optometrist or associated with their institution. I personally can't get over the risk of infection and I don't think the benefits outweigh the risks. So I personally don't recommend orthokeratology to my patients. So looking at something less invasive, let's look at, let's look at spectacles and like soft contact lenses, not orthokeratology. So spectacles with progressive ads, with bifocal, it's a similar theory as that of orthokeratology, trying to prevent that peripheral, peripheral defocus. So it reduces that hyperopic blur, as we showed in the previous thing, and specifically during near work. And they also argue that it reduces accommodative effort. And so studies in the US and Finland and Denmark showed no significant effect. And there was one paper out of Canada that actually did suggest that there may be an effect. There have been claims of success with bifocal soft contact lenses as well. But this is probably where the biggest interest lies, in this defocus incorporated multi-system segments, also known as DIMS. This is the concept of the Myocyte lenses, okay? So Myocyte is probably the one that is most used, most popular from what I see in Canada. I'll get asked a lot about these. So Doc, do you think that we should spend that extra money and on these very expensive lenses for myopia? Do you think that they make a difference? And how it works is kind of a similar kind of concept to orthokeratology. So you have that central optical zone, okay, right here, and it's 9 millimeters in size, and that's to correct the distance refractive error. Then there's this annular zone with multiple segments, and it's a positive power of about 3.5 diopters to kind of, again, defocus and bring that image forward. And the thinking that this introduces that myopic defocus and provides a clearer view. And the diameter of that is 1.03 millimeters. In their randomized trial, they stated that this reduced myopia progression by 55% and axial length by 62% compared to single vision lenses. And it's important to note what they're comparing it to. So I always approach these things with a little bit of skepticism. And I took this picture for Michael Wan as well, because there's a lot of money to be made in spectacle and contact lenses. I'm not saying that there isn't something to it, but we also need to be careful of the behemoth that is selling glasses for revenue. The revenue of eyewear market amounts to billions of dollars estimated in 2022, and the market just continues to grow, with a growth annually of about 5%. This largest segment is spectacle lenses, right? So actually, it's not cosmetic eyewear. And in relation to the population, the revenue is estimated to be like $17 per person, which is not insignificant. And the average person is expected to have 1.25 pieces of eyewear in 2022. So everybody's got it. So, okay, well, which treatment's the best? How do we compare one versus the other? Is there a good comparison of one versus the other? The best article to date is actually from 2016, so it may be a little bit dated because there's not as much about the DIMS lenses. And this includes atropine, orthokeratology, progressive spectacles, and it's a comparison with placebo or single vision spectacle lenses. And what you see here, I know it's a busy slide, but here are all the different types of treatments. And what I'll draw your attention to is these top 3 interventions are all atropine, okay? And you can see that the use of high dose, medium dose, and low dose atropine cause as the least amount of axial length or change in refraction. sorry, this is change in refraction, okay, and have the lowest change in axial length. They don't have orthokeratology here, but they do have orthokeratology here, and showing that orthokeratology is quite effective in slowing the progression of myopia. So this is kind of the study that I quote to date. I'm hoping that they'll do another one in the near future. And then there are other treatments that are coming down the pipeline. And this repeated low level red light is actually really interesting. And this just came out in December. And this is an alternative therapy. And it's looking specifically at the manipulation and manipulating light in order to mimic the effect that bright outdoor light exposure brings to the eye. The authors of this study point out that from a pragmatic reasoning, it isn't feasible to simply have all children live a greater proportion of their lives outside, as I alluded to earlier. So they hypothesized that by simply exposing children to specific wavelengths of light at specific intensities, the interval, we may see some protective effect. So a total of 5 hospitals throughout China participated by recruiting patients from the vision clinics. The children were followed at regular intervals throughout the trial duration, and measurements were taken at 1, 3, 6, and 12-month intervals. The compliance was actually quite good, with 85% of all subjects completing the testing at 12-month mark, with only 6 participants actually discontinuing. And the intervention was quite simple. So each participant was provided with a desktop light therapy device that was connected to the main study database in order to measure compliance with the task. The children simply had to look at a light for 3 minutes, twice a day, 5 days a week. The 2 daily sessions had to be separated by a minimum of 4 hours. And the main hypothesis was that this would decrease the rate of axial length and increase and decrease the rate of spherical equivalent refraction. So what were the results? Axial length data, as you can see, the difference in progression was 0.26 millimeters, which corresponds to a 69.4% reduction in myopia progression. As for the spherical equivalent refraction, the difference between the 2 groups was minus 0.59 diopters, which corresponds to a 76.6% reduction in myopia progression. They did not report any serious adverse effects for the treatment. So myopia continues to grow. I think it's a very interesting topic. You know, I think treatment paradigms vary, and there's no clear data to suggest, you know, we know when to start, but we don't necessarily know when to stop or restart. So I hope today I've been able to identify some of these objectives, to understand the burden of disease, and I've hopefully convinced you it's quite significant, to understand a little bit more of the pathophysiology, and to discuss the different types of treatment options. So when you're at that dinner party, are you comfortable answering some of those questions that, you know, people may have of you? And I continue to have questions and questions for the group. And I'm always interested to hear people's perspectives. So should we be advocating for change for our patients, particularly our kids? Should we be advocating for more outside time and recess time? You know, I'm from Saskatchewan, so, you know, we always say, you know, you went up as, you know, we would always go outside, even if it was minus 30, there were no limits. And so, you know, I sound like an old timer. You know, I went to school both ways in bare feet in the winter. But I find that for my kids, they stay indoors a lot more frequently for recess. Should we be advocating harder to our schools that they really do need that outside time? Are we aggressive enough in treating myopia? Should we be more aggressive in treating myopia? Should ophthalmology, if the burden of disease is that high, who should kind of be taking the reins and developing this? You know, optometry, ophthalmology, where's the relation? Where does that, how do we work together with this? And should we be developing national guidelines for the treatment of myopia? Thank you, and I'm happy to take any questions.
Stephanie, thank you for that. That was amazing. Very comprehensive. There's a lot of discussion in the chat box. I'll throw some questions your way if you don't mind.
Sure.
I'll start with John's question here about red light therapy, just because we ended there. Was there any rebound effect after discontinuation?
They haven't looked at the rebound yet, so
Okay,
I can't answer that question yet.
fair enough. So we'll look forward to you coming back to Toronto to answer that one for us. Steve Kraft just makes a good point that more outdoor activity also helps with the burden of obesity. Point well taken. Now, with respect to light, you know, you're just mentioning it's minus 30 in Saskatchewan. It's actually pretty cold in Toronto this week. We're probably minus 20 and below. Is putting the kids up to the window sufficient if we're just talking about sunlight, or is there something more to outdoor play?
So the studies have actually looked at like the intensity. So the lux of the light is like the measurement for the intensity. And it's about it seems to be about the intensity of the light. So if the lux is there, it should be fine. So, but yeah, to Steve Kraft's point, it's not just obesity, it's also socialization and language development, and also fine motor skills. So when I talk to my neonatal colleagues, they're also counseling the patients on screen time, because they find that babies who spend a lot of time on digital devices, their gross motor and fine motor skills aren't where they would expect them to be, even with accounting for their delay for prematurity.
Great. And lots of questions here. I'm going to try to get through all of them. Nancy Epstein's asking, with respect to outdoor activity, what about reading outside? Does that help?
I don't know. That's an interesting theory. That would be interesting to test, right? You get the sunlight, but you're doing the concentrated near work. I don't know.
All right. A question from Marissa. Up to what age would you start, or would you treat with atropine eye drops?
What age would I, up to what age?
Yeah.
I think if there is, so those age groups were to approximately 8, but I will do older children as well. If there's myopic change, I will try. I do warn my teenagers if they're going to start. I said, well, you know, sometimes we don't know the effect of, is this, you know, myopia control, or is this that you're just reaching your limit with respect to your growth, right?
On that note, I actually had a question myself as you're showing those slides. So the atropine studies have cessation after 2 years, and then we're seeing some rebound in all of the groups. Has anyone looked at a longer treatment period?
So they are looking at longer treatment periods. They're also looking at when to restart, because like I said, we know when to start. We don't know when to stop.
Okay. And how early can you start? There's a question here from Nancy again.
How early can you start? So the guidelines say that you can, you know, the guidelines had that specific age group, particularly in the Atom group, but I would argue you could probably start sooner than later, because, you know, you're at a higher risk of, the younger they are when they start, the higher myopic they will be at the end. So I kind of try and follow the guideline and say that if there's a 1 diopter change of myopia over a year, I will offer it. I don't know if any of the other pediatric group have a comment to that as well. So, because the reality is we also can't treat all the myopia, because then we'd never see strabismus or any of the other ocular conditions.
I think that's a good point. Can I just make a comment? I think what you said is that a lot of evidence is for a specific age group with a specific amount of myopia. So again, there are questions coming up about high myopia. Again, we have no evidence. What about premature babies who are myopic? Again, there's no evidence. I personally, if the atropine is working, I as long as the parents can afford it, I say you can carry on with atropine for as many years as you like, in terms of avoiding that rebound effect. Because again, whether you stop it at 2 years and get, again, 1 diopter of regression over 5 years, that's still something that some people want to avoid. So, and the higher the pace. One question I have for Stephanie, and this is a practical point, is that over in Ontario, IOL master for children, which is to measure axial length, is not a covered procedure. So parents have to pay out of pocket. So do you personally rely on refraction to judge your outcomes, or do you actually insist on an IOL master, and is it covered over there?
So I personally do both. So I measure the axial lengths with the IOL master, and and obviously the refraction. Our axial lengths in Alberta are covered once for 5 years. So they do have to pay out of pocket for that. If the parents can't afford, then I'll just comp it. But usually, I mean, let's be honest, most people that are being treated are of, higher socioeconomic status, because the drops aren't cheap either, right? So the drops, the drops have to be compounded by the pharmacy here, and I'm sure it's the same there. So, that is not cheap to get compounded drops every month. It's an added expense.
I bring that up as well because at SickKids we kind of do the procedures for free, including the IOL master. But I wonder if this is an inhibiting factor for people in the community using this, if they have to start doing these extra procedures and parents either don't pay for it or it becomes an issue. So that's interesting. I think doing it just by refraction is fair enough. And if, as you said, these highly motivated parents are willing to pay for the IOL master as well, then that's great. But it shouldn't stop people in the community using the atropine, just a point to bring up. And
so with EPSA, we are trying to change that with the billing with the AMA and try and get axial lengths for children covered. But, you put an age restriction on that, right? So that way, if a child, an axial length for someone less than, let's say 18, right? And covered at like a lesser fee. So
with Andy online, I think that's something we should consider here as well, I guess.
Yeah, no, I agree. Typically we go by refractions, but usually we'll do 2 refractions over usually a 6 to 12 month period to prove, as you were saying, an increase of one diopter. The one thing I do tend to, as I noted in the chat, often if they're a little bit older, continue the atropine a little bit longer, usually 0.01 or 0.02%, just because I find there is a big increase in myopia between 7 and 10 in many children. So if they are sort of moving up, and I explain exactly as you said from the studies that we're looking for a 50% decrease. So, if they're 9 or 10 and they haven't changed by a whole lot, then you explain to the parents that, well, chances are we can continue this a number of years, but you may save 1 diopter difference. But if you've increased by 1 or 2 or 3 diopters over a few years, potentially even with atropine, then they understand that you are looking at a more significant change. So I think a parent buy-in and explaining it in detail what you're doing, because it is a huge task that they're undertaking, is really important.
I also see a question about, should we be prophylactically treating before the onset of myopia? And the reality there is that it's still an intervention. There's still risks, and the studies are not based on using atropine to prevent myopia. It's to slow the progression of myopia. So I probably wouldn't recommend it, because then when would we start if we were to do that, right? At 2, at 3, you'd need probably a risk stratification nomogram to kind of help with that, right? So.
Well, that's a good question. I think Nazanin's got her hand up, but maybe we can go to her.
I just wanted to ask, so all of this time we've been talking about people who are myopic in both eyes and people who have no underlying pathology. Just in terms of, other pathologies, and somebody sort of talked about sort of prematurity, but other things like patients, for example, who we have had cataract surgery are pseudophakic and we're getting a sort of unpredictable refractive outcome, or glaucoma patients and so on. What about those patients? Should we?
Well, there's no research there. That's the problem, right? Everything's done on healthy kids that just have basically axial myopia, right? And you'll see this come up in the listserv, like, what do we do with our high myopes that have been treated with ROP? What do we do? There is no evidence there to date. So if I have a highly motivated parent, I try to counsel them that, yes, I think we could try, but the research isn't there, right? And I document that very, very, very well, right?
I just wonder if anybody within the panel has got experience in actually treating their patients with this, and have they found any evidence?
I've done a few ROP patients, like Stephanie was saying, and in one of them, there actually seemed to be a marked decrease in the increase in myopia, and they were really moving quickly, big increases. And the other few kind of at 5 or so. So I'd say about a third. 2 of them improved or stabilized, and 3 of them it didn't make any difference. As well, with the anisometropes, you kind of wonder where you have a -12 or 13 and a whatever plano or +1. Often they don't change over time a whole lot, the high myopes, but I discuss that with the parents and watch the same as you would with the others. And if they are increasing in the myopic eye, then we'll treat them and see what happens, realizing again that there's no research on that.
Okay, I'll do one more question, just because it is a very practical question that I'm sure many parents are thinking. So Nupra has a great question. Is there data on combined treatment? So maybe peripheral defocus and atropine, because I could see parents sort of doing both things. Any thoughts on that?
So there are some specifically on orthokeratology and atropine. And I was going to put it in, but I just didn't have enough time. So yes, there are studies on atropine and orthokeratology, and it actually suggests that there is an additive effect, that they're beneficial. So I haven't, and like I said, I haven't seen anything about those defocus lenses and atropine. I don't know, has anybody else seen them? Maybe I missed an article there. So
I think there's some articles in optometry where they're pushing that it is additive, but I haven't been convinced that they're good studies, but there might be some improvement there.
So just one another practical question to, sorry, Amandeep, I know you want to finish it off, but do sunglasses, A, do you recommend if somebody's on atropine, and B, do they have a sort of a I don't want to say negative effect, but does it cancel out the effect of good sunlight?
So for the treatment of atropine, the 0.01%, they actually found that there was very few patients that were actually photophobic, or and they had still had good accommodation and near. You're seeing it more in the 0.05% in the LAMP studies, and those patients were provided with some sunglasses if they needed to. Does sunglasses specifically affect stop the beneficial effect? No one's actually specifically looked at that. I think I've thought about that intuitively, right? Because there's a big push for kids to wear sunglasses because they say it prevents disease, ocular disease. But if you have the wraparound sunglasses and there's not a chink of sunlight going in, I would expect that it would reduce the benefit of sunlight, but there isn't anything specifically that I've seen.
Is it the fact that the UV light is blocked and the sort of infrared spectrum isn't kind of potentially helpful, or should we all worry about wearing sunglasses now?
Well, I mean, it looks like the red spectrum, as long as it's getting through, may be beneficial, right? So if you carry that red light study, so therefore, as long as that's getting through your sunglasses, you should be potentially okay, right? So.
Right.
All right, Stephanie. I'll give you, there's actually one more question here. Do you start atropine therapy in children who are already high myopes?
So if they're progressing quickly, yes. Yeah, I do.
All right, well, we are well over time, but there's so much interest and discussion in your topic that we had to let it go. But in the interest of time, I want to thank you, Stephanie, for joining us this morning. It's 5:30. It was 5:30 in the morning when you started, so thank you very much. We couldn't tell that it was that early in the morning. That was a fascinating talk, and we look forward to having you in Toronto for an update when possible. But thank you very much. That was great.
Sounds great. Thanks.
Have a good
Wonderful,
Friday, everyone.
Stephanie.
Thanks a lot.
Bye, Stephanie.
Bye.